In this video, I want to address the question of whether or not FME is too new and unproven to be worth trying. Would you be a guinea pig for doing an FME right now, given that there are less than 200 cases, perhaps even less than 150 total cases? We know Dr. Nuaz has a little over 100 cases at this point. Dr. Manueli has some, Dr. Casey Lee has some, and sporadically we're seeing new doctors take up FME in North America in various places. And yet still the total is, like I said, less than 150 probably total cases. Meanwhile, Custom MARPE has thousands of total cases. MSE type 2 has maybe tens of thousands of total cases. Does this mean FME is dangerous? Is it risky? Would you be essentially a trial patient if you were to do FME right now? And I think the answer to that question is no. And the argument that I'm going to make is that if FME were fundamentally a different technology than other skeletal expanders, than Partners Custom MARPE, than MSE Type 2, then yeah, I would say wait. However, FME faces the same exact dangers and obstacles that other skeletal expanders face, which means that as long as a doctor who provides FME has had experience with other types of expanders, then they know what to look out for in terms of generally the dangers that skeletal expansion faces. And those dangers are asymmetry, overexpansion, orthodontic problems related to the types of specific orthodontic challenges that skeletal expanders create through the formation of diastemas, through the formation of Brody bites if expansion is too large, managing diastema through non-diastema protocol, the potential need for intervening on the mandible if expansion gets too carried away with something like SFOT or MSDO. But most importantly, what it's really about, the dangers of skeletal expanders really come down to orienting that jack screw. These are dumb expanders. As I said in my last video, any skeletal expander, whether it's an FME or whether it's a KLS Martin TPD or an MSE Type 2 or a Partners Custom MARPE, they are dumb, they are brute, they are Newtonian. They go left-right. They have no sensors that provide feedback to them if something is going wrong. So that if the expansion screw is not perfectly perpendicular to the symmetry of the face, or perhaps parallel, you could say, that you will expand and create an asymmetry, or what's probably even more common, at least with experienced providers, perhaps the expander is oriented perfectly. Maybe the expander is placed in a perfect left-right orientation without any propensity to create a cant through a vertical asymmetry or a yaw problem by slicing one half of the maxilla forward while the other one goes back. Perhaps it's oriented perfectly, and yet during expansion itself, as the skull introduces forces onto that MARPE, perhaps due to a lack of dimensional stability in that appliance, particularly in the Custom MARPE variants, in MSE variants, not so much in the FME. That is the great advantage of FME, is its dimensional stability. Perhaps those new forces that the skull introduces mid-expansion actually twist the expander and disorient it from perfect alignment in innings 4, 5, 6, 7, 8, 9 of the proverbial baseball game of expansion. In other words, maybe in inning 1 everything is perfect. By inning 4 or 5, as the intracranial forces are collapsing down hard on that expander, shit starts to get wonky. So these are the challenges that Custom MARPE faces. That any MARPE faces, rather, not just Custom MARPE, any MARPE, including FME, all skeletal expanders. I should add one more, and maybe this is a challenge that FME actually doesn't face, but that I would say is a typical challenge that any MARPE provider faces in providing skeletal expansion, is the risk on the teeth. If you have a tooth-anchored appliance, of course not primarily a tooth-anchored appliance, these are skeletal appliances with screws that go up and through the palate. Some of these appliances have arms, though, that come off of the skeletally anchored body and then attach to the teeth, usually the molars, to provide additional anchorage so that the split can occur. If screw drag occurs, in other words, if the MARPE screws cut through the bone, then what can happen is force can be applied to the teeth, transferred through those molar attachments, and then that can lead to flaring of the molars, which can be destructive if it becomes severe enough. It's definitely something that has to be managed. And another challenge that MARPE providers face, not something that FME providers face actually though, because there is no dental anchorage with FME. It's purely skeletal. There are no arms, which also increases the comfort of that appliance. I've digressed a little bit. Let me get back to the core topic. What I'm arguing in this video is that you're not a guinea pig for doing FME right now. From a danger point of view, maybe FME is not all that it's cracked up to be in terms of efficacy, in terms of how much better it is than custom MARPE. Fine, I yield that. And personally, I don't care either way. I mean, it makes me happy to see that there's a new and improved technology that can predictably get people the skeletal expansion that they want, but I actually have no dog in this fight. I'm not a stakeholder in FME. I don't represent the company FaceGenix. I've never actually even communicated with the leadership over at FaceGenix or anyone there for that matter. So I actually don't care whether or not FME is legit. I'm just here to report on whether or not it is. And if patients are looking for a skeletal expansion solution, I'm just here to point them to what seems to be the best option at the time. Is that FME? It seems like FME right now, at least for most patients, but the topic of this video is actually just whether or not it's unsafe to do FME right now, not whether or not it's an absolute slam dunk home run to do an FME over a custom MARPE. And what I'm saying is, no. The technology with FME is not so fundamentally different than custom MARPE or MSE that there's potential new pitfalls with it that providers can fall into due to a lack of experience with having used the FME. That the challenges are fundamentally the same. So that if a provider has, let's say, 250 custom MARPE cases under their belt, they've seen asymmetry. They've seen the pitfalls of misorienting appliances and not zooming out when doing the CBCT analysis when they're designing the appliance to make sure that the appliance is properly oriented with midfacial skeletal symmetry and so on and so forth. They've seen screw drag. They've seen failure to split and the need potentially for a midline piezo cut in certain adult patients that have a lot of resistance. They've seen how challenging it can be to finish a patient that's been overexpanded with a MARPE and that has been surprised with the need to do a $15,000 or $20,000 SFOT procedure, or perhaps even a mandibular symphysial distraction, which could be in the tens of thousands, as that is an orthognathic procedure. And having seen all that, they would know basically how to safely implement an FME expander, as the process is very similar between custom MARPE and FME. You take a CBCT of the patient, you get your baseline information of the anatomy that you're dealing with, you do the iTero-scan and get the STL files that show the patient's bite, you send that data off to the lab, whether it be, in this case, we're talking FME, so FaceGenix, but the process is very similar with custom MARPE. You send it off to them. You tell them basically where you want the appliance to sit. The lab sends you back a custom designed plan for an expander for that patient. You double check it. You make sure it passes the smell test. You zoom in on it. You make sure the symmetry is right there. You check for midfacial landmarks to make sure the symmetry is all good and that the TAD anchorage is not striking any roots of teeth or otherwise going to be problematic. And then you order the appliance and have it delivered. You place it in the patient. You make sure you don't break the TADs during installation. You make sure the patient's numb properly. The piezo cut would be identical between custom MARPE and FME, and so on and so forth. So that's my position. My position is really that FME ought to be considered a modification of the skeletal expansion technologies that we've been building upon since 2018 and even earlier, and not some fundamentally new thing that has unique challenges that require hundreds of cases of actually doing the FME in order to avoid those dangerous pitfalls when treating patients. Now, do I think that it's okay to be a provider's first FME patient? That's a question that I got recently inside of The Joint. And I had a patient actually become someone's first FME patient. I had a client, rather, become someone's first FME patient. And I was not sure whether or not that was a good idea. I think it's hardly ever a good idea to be the first of anything, or even the first dozen, or maybe 3 dozen of anything. But this patient went for it and actually ended up having a complication with his FME. A TAD broke. One of the front TADs broke in that FME. And whether or not that was a provider error or an issue related to the fact that the TAD was too long. Actually, this is a known issue with FME. I guess I'll take a brief tangent just to say that probably the biggest issue we know about with FME is the length of some of the TADs that are included with it. In this case, I believe it was a 21 millimeter TAD. That's over 2 centimeters long at the front of the appliance that it broke sort of probably, I would say, 6 millimeters from the end. So right deep up inside of this patient's palate, the TAD broke. And now that patient, whether or not he leaves that there forever or has that surgically removed, it's a complication no matter how you look at it. And I think, and I'll yield to the doctors on this in terms of totally understanding the mechanics of it, but basically there's too much daylight between the FME and the roof of the mouth. It's not snug enough into the palate. The glove doesn't fit tightly enough, so to speak. And so what happens is there's this section of the TAD between the expander and when it actually fastens to the palate, where it's just exposed naked TAD, and it's wasted length essentially. And the longer it is, of course, the greater the lever force on the TAD, which means more likely for the TAD to break under those torque forces, I guess is what they would be. If there are any physicists in the chat, please correct me on that. But anyway, this patient was this provider's first FME patient. He did have a complication. Arguably, it was a Phasegenics design problem, not a provider problem. But I'll just leave that out there as a fact. You can assess it as you will. But I would say it's inevitable that a lot of people are going to be someone's first FME patient as FME becomes more ubiquitous, but probably best to avoid that. But as a technology in and of itself, I view FME as just a variation of skeletal expansion. And as long as a provider has lots and lots of custom MARPE and MSE experience, 90% of the potential pitfalls that can occur with FME, they will be accustomed to and will know how to deal with and will probably avoid. So that's my 2 cents on that. And if I forgot anything, as usual, let me know in the comments below. Hope y'all enjoyed that, and I'll talk to you soon. Peace out.